getting the confidence of the patient that they can do these things, it usually starts with that consultant or physical therapist, at least to get them into place where they feel comfortable and they feel confident to engage in some of those movement therapies. But it's really important for them to be engaged, and because we definitely do want to get them in a place where they're comfortable doing it and confident that they can do it correctly.
Welcome back, every Bendy Body, to the Bendy Bodies podcast. I'm your host, Dr. Linda Bluestein, the Hypermobility MD, a Mayo Clinic-trained physician dedicated to helping you navigate Ehlers-Danlos syndromes, joint hypermobility, and complex chronic illness. Today, I'm joined by Dr. Dacre Knight, who is not only an expert in EDS, HSD, POTS, and mast cell disorders, but is also joining me as a recurring co-host. Dr. Knight recently transitioned from the Mayo Clinic and is now the founding medical director of the UVA Ehlers-Danlos Syndrome Center, which is officially partnering with Bendy Bodies. Today, we will be talking about what thoughtful, systems-based care actually looks like for EDS, HSD, POTS, and MCAS, including how to prioritize treatments, set realistic expectations, and avoid common pitfalls. As always, this podcast is for educational purposes only and is not a substitute for personalized medical advice. Stick around until the very end for our special hypermobility hacks. Let's get started. I'm super excited to tell you about the Bendy Bodies Boutique. I am so proud of our fierce styles and flexible designs. These are created by hypermobile artists for hypermobile shoppers. There are so many fun items from clothing, accessories, home goods, and my favorite are the bags. I especially love the Weekender tote with one of the EDS Tough designs. Whether you're shopping for yourself or someone you love, there's so many options to choose from. A portion of the proceeds goes to support EDS nonprofit organizations. For more information, please visit bendybodiesboutique.com. Okay, well, I am so excited to be back with Dr. Knight for another great conversation. And this time we're going to be talking about how we treat these conditions: Ehlers-Danlos syndromes, hypermobility spectrum disorders, POTS or postural orthostatic tachycardia syndrome, and mast cell activation disorders. It's great to see you again. How are you doing today?
Yeah, so glad to be here. Doing great. Excited for this episode.
Wonderful, wonderful. I know that we both know that these conditions, there's no like magic treatment. So trying to chase a magic treatment is not what we're trying to share with people. We're trying to share some ideas that they can try, things that are maybe beyond prescriptions, protocols, and quick fixes. Although in the next episode, we will be talking about kind of our favorite medications to prescribe, our favorite treatments. This episode is going to be more about strategy and sequencing and, kind of coming up with a realistic plan, not as much, chasing some kind of magic treatment. So that's what we're going to be discussing today. And I'm excited to have this conversation with you because I know we both have treated a lot of patients at this point. And of course, you learn a lot, right? I learned something really interesting from somebody just yesterday. It's every day is different, right?
Oh, totally. And, I agree. It's hard to find the magic treatment, but I may add a soundbite here and say there is some magic in the process of it. And I've seen some real turnarounds from patients who, and I'm just amazed by it too, but at least just, recognizing the diagnosis and then learning about it and learning how it affects them. And then the whole process, it really entails some magic to the process of uncovering things that can be treatments for the patients that really help them get back to living. And that's what we're all here for.
Right. Absolutely. I imagine you feel the same way. I want to cry whenever I hear people say, well, I was told that there was nothing that you could do. And so that makes me so sad.
Totally. And it may feel like magic to patients when they get somewhere to be with someone who finally does listen and understand, right? So
that's true.
It can be few and far between, but we're trying to limit those bridges and try to be more connected and more available to patients and other providers who want to learn.
Right. And get them connected to the resources that they need sooner, which is, of course, the point of the UVA EDS Center, and so exciting about that. So
exactly. early diagnosis and getting children involved and all the rest. Yeah.
Yep. Yep, absolutely. Okay, so let's start with when you first meet a new patient with EDS or HSD. I guess that kind of assumes that they have a diagnosis. So let's say maybe they do or you suspect. We'll make it more open than that. What are your first priorities? And now I'm thinking in terms of um, you know treatment, but you could feel free to add in about diagnosis as well if you want.
Well, that's a great question because we find that one of the big difficulties with making these diagnoses to begin with is that they can come in all different shapes and sizes and varieties and levels of severity. So, really, the top priority, I'd say, is to get an understanding of where the patients are at that time and that moment, and what is a little bit about their medical history and background. What is more about their understanding of their condition, if they have some understanding, and I'd say likely they do. If, like you mentioned, they already have the diagnosis, very likely that they've gone to Google and tried to do a little research on their own, which is totally fine. That's what we all do in any situation of our lives these days is this time. But I would say with those things, I want to get a good idea of what are the levels of severity of the condition, what are their major impediments, how functional are they, about their daily activities. And so then that can inform us of what level we're starting at. We certainly don't want to jump the gun and prescribe too much too soon. So we, as with any medication or treatment, we always say, start low and go slow. So at what starting point is that? That's what we want to be informed about.
Yeah, and I agree. I had a patient just yesterday who, when I was reading through their paperwork and reading about one of the concerns that they had, it didn't feel to me like it was as big of a deal. But then as they were describing it and how it impacts their life, I realized it was a bigger deal. So I think that's an important thing for patients to realize that when you are talking about a particular symptom or a particular problem, it's really, really helpful to us to be able to explain how this impacts your life. I was having a problem with my wrist, and I had bone grafting surgery a number of years ago, but the at times I had no pain, but I had difficulty like literally opening doors. Like I would literally like wait for someone else to open. If it was a heavier door, I'd wait for someone on the inside to open the door rather than if it wasn't an electric door. So I think that that's an important thing, to meet people where they're at and for them to really let us know where they are at.
For sure. And to just kind of get a whole better understanding of the whole picture, right? And like you mentioned with your wrist and the impediments it causes during the day, we may be able to understand better what the patient is inclined to do or what they had been doing prior to illness or prior to symptoms so that we may incorporate other resources or other treatments that may be beneficial to them. So not only kind of the standard physical therapy and occupational therapy, but are there, dietary issues we need to involve nutritionists, or are there other, health coaching things that we can do or integrative medicine steps that we can take. So we really, really do want to get that full picture for all those reasons.
Yeah, definitely. What do you think when you think about symptom relief and, you want to be thinking about, okay, how can I address these certain symptoms, but at the same time, you want to be focusing on the long term. So I guess how do you balance the short term and the long term when you're seeing a patient?
Yeah, that's a really good question when it pertains to treatment, of course, because we can bring out the strongest medications and wipe away pain instantaneously, really, if we want, right? But it's likely just not sustainable over the long term. So we do have to keep that in focus. What is the long term expectations and what is the trajectory of treatment that we want to keep in the picture? And because we know that these conditions are likely lifelong, not that symptoms have to be, but the conditions that predispose to those symptoms can be. So we want to have treatment tailored to that. And again, getting back to what are their daily activities, what is their job, what are those things that they enjoy doing, hobbies, and so forth. So that's where we want to find, if we go back to the adage of starting low and going slow, we want to find those treatments that are least invasive and that are least disruptive and have the lowest burden to their daily life. If you have to come in for an injection every day, then what's the point of that? Because you're not going to be able to get back to work if you're spending all your time driving to and fro. So we have to keep those in mind. So again, meeting the patients where they are, is this, going to be, oral medications or other treatments and therapies that they can do at home, so they don't have to come in and meet someone if it's therapy. But that's what we want to keep in mind, because ultimately, if it is medications, we want to have something that's a good safety profile, low risk of side effects for a long-term use. And if it's some type of therapy, we want to have some way of delivering that patients can start learning those things on their own and to build up their self-management skills. And so again, the burden of treatment is lessened by that.
Yeah, so that over time they're less and less reliant on the healthcare system. I know when I was at my worst in like 2009, 2010, 2011, you know, I my whole schedule was like doctor's appointments, and I felt like my illnesses were running my life. And thank goodness it's not like that anymore. But I do feel like a lot of people, yes, they can really end up with, they have so many appointments and keeping track of all their medications. And I mean, it can be a really huge burden. So oftentimes they'll get labeled as like, non-compliant, right? But really, we're asking them to do so much nowadays, keeping track of, if they have multiple different doctors, maybe they're responsible for kind of, getting that information from one office to another if they're not all part of the same system, which, again, UVA, that should be a big advantage there, that people will be able to, actually have people within the same network. That'd be really huge.
Yeah. No, and that's part of delivering the care. And there is a focus of medicine now that we call minimally disruptive medicine. And that's what that focus is to try to lead medications and treatments and therapies that are patient focused. And that means, focusing on what that care involves for what their life brings and what those targets may be, and in just overall reducing the treatment burden. If we can get adequate treatment with the lowest amount of burden possible, that's the best target.
Yeah, definitely. And I think another challenge that a lot of people with these conditions have is if they go to, a their regular doctor, their regular, PCP, they're probably seeing a lot of patients every hour, or every appointment is fairly short. So they're more used to thinking in terms of, oh, if this, then that. So they're kind of, they're not doing a one size fits all kind of treatment, but it's a little bit more that way. Whereas with these patients, like you already said, they're so heterogeneous, they're so diverse in their presentation, they're so diverse in how these conditions impact their quality of life. So I think that's another, really, really challenging aspect of treating these conditions. And I think another huge goal of this podcast has always been to get more and more clinicians interested in treating these conditions and helping them to realize that, if you learn about these conditions, you will have additional tools in your toolbox and you can help more patients. But can you talk a little bit about your feelings on this, how we treat people in a more traditional type setting, and how what people with these conditions might need is different, and what do we do about that?
Well, I would say one of the clear differences is the complexity, like you just mentioned. And it doesn't fit into that standard model, as you just pointed out, where someone goes into a primary care doctor and they've got cold symptoms, they got high blood pressure. You can get to a pretty quick algorithm pretty directly and move on to the next patient and just start churning through patients, 15-minute visits all through the day. It really just doesn't work that well in these complex cases, though, where so many systems can be involved and the symptoms can be kind of ambiguous and mask other things. So it does take the time and attention. And once we get there, then we keep all of those things in mind that the symptoms may be drawing out as far as treatment goes. So, for example, if let's take the most common presenting symptoms, pain, and the fatigue that goes with that is a sequelae of chronic pain. So, if we're talking about treatments, and we say that someone is fatigued, and the general population otherwise normal patient who maybe had, a knee surgery and has been, just recovering for a few weeks and kind of debilitated muscle weakness and things like that. We just get them back into physical therapy, start strengthening those, and it's a pretty quick turnaround. The problem with the complex chronic conditions is that it doesn't work like that as well as we want it to. It can work, no doubt, and it just takes a little bit more patience and a little bit more kind of gentle movements and time. Uh, but when we're applying those things, we have to think about the burden to the patients, not only with the time when we're talking about having to travel, but there's also burdens we commonly talk about costs. And so that can be included in not only the medical care costs, but the cost of transportation, cost of gasoline is going up, the cognitive load that it takes to go through these things. So if someone is already burdened with chronic fatigue, then how do you really expect them to just jump up out of their chair and start, going about an exercise routine? So we have to keep all of those things. So financial, physical limitations, cognitive load that is required from all of these treatments. So it's not usually the standard of just prescription and go about your day and see you again in a few months and you'll be right as rain. So we do have to have a little bit more uh, gentle and ease of care and an appreciation of the widespread nature of the symptoms and how variable they can be and how impacting they can be.
And as you pointed out last time, if people, which is the common scenario, right, they don't get diagnosed for usually years. And so things continue to, unfold and you get more sequelae, and it's even harder to untangle all of that when it's been going on for years and in some cases, decades.
Right. And I mean, ideal scenario, I mentioned the primary care model, 15-minute visits, churning through the day. If that primary care doctor is well adept at recognizing connective tissue disorders and notices that there's maybe a history of joint instability and laxity and then chronic pain, then it's not to say that that visit can't be short either, at least as an initial visit. But there has to be that basis of knowledge to work from and that, you know, anticipation of seeing these patients in clinic because likely these patients are all throughout the primary care system out there, just unrecognized though, and as you pointed out, can lead to diagnostic delays.
Okay, so let's talk about sequencing and what to do. This is a common problem when patients are having so many different symptoms, everything's flaring all at once. How do you decide what to address first?
Yeah, and that is really tricky because it seems like maybe sometimes you just want to start everywhere at once, and really great if you can do that. But as we pointed out in previous episodes, there's likely some things that are tying together, and if we can kill two birds with one stone as far as symptoms go, and target a treatment that may have improvements in other areas, then awesome. So when we see patients come in with this wide array of symptoms and systems that are affected, then I would think about connective tissue disorders, whereby there may be dysautonomic issues. There may be, connective tissue issues that relate to mast cell activation. And so those would kind of be at the forefront. Now, of course, we think about all the, IBS and gastrointestinal problems and any other neurologic or headache problems and things like that. But usually those are the ones that we may be lucky enough to see an improvement if we get some of those first ones targeted up front. So that's where my decision making would usually start. So, how can I understand what symptoms are present that may be a constellation of either a hypermobility disorder or an autonomic disorder? And then, what are some suitable treatments? Again, if we're talking about minimally disruptive, what are some treatments that they can afford that are not going to have any major side effects that may actually improve other areas and organ systems? So that's kind of generally how it would start, I'd say.
Definitely, I've found, and I would imagine you found the same thing, that, like you're saying, you sometimes you treat the mast cell problems, and then the autonomic dysfunction gets better. So if you can address, right, the whatever seems to be at the root of the problems, that's going to be oftentimes more helpful. But there are times where, like the medications that you might want to prescribe for autonomic dysfunction are going to be a little different than what you would prescribe for the mast cell problems, or a little bit different than what you would be prescribing for pain. So, in terms of factors that would push you to focus on autonomic dysfunction first, are there certain things that, would make you think about that being the highest priority?
Yeah, certainly would be. And that's, again, probably a a good understanding for what we can elicit from the patient's description of their condition. And if I get an understanding that they feel these cardiovascular neurologic effects a lot throughout their day, throughout their week, and this severe lightheadedness that impedes them from being more physically active, or maybe they've even had some episodes of passing out, or getting to the point where they almost feel like they're passing out, heart rate changes, palpitations. Those are kind of standard ones. Some that are a little bit more tangential, but may actually still be related, are some of the temperature issues, maybe even gastrointestinal issues that can be related to that. So it's really all mixed in. But I'd probably start with some of the standard ones, being, at least for an autonomic disorder, being sort of that neurologic, cardiac connection between heart issues and dizziness and lightheadedness, particularly with position changes. When we were talking about upright or orthostatic, and if that is something that's high on the list, then yeah, then certainly we would probably start with those treatments first.
Okay. Have you seen problems with clinicians treating the wrong issue first?
Well, yeah. Yes is the short answer. I guess the longer answer is, what are those conditions? And it ranges. I guess I would say it probably ranges to the background and knowledge of the clinician and what they have experience and training in treating. So whether it's rheumatology, sometimes I see patients being treated for what we would call seronegative rheumatoid arthritis, where,
Mhm.
oh, your labs look normal. They keep coming to a rheumatologist. Maybe there's a little bit of some findings on x-rays that make the joints look a little fuzzy, or some erosions and things like that. Sometimes it's really hard to tell on x-rays, though, particularly if they've got a lot of symptoms of joint issues and pain and swelling and things. So that may be just an example of one area in rheumatology, or mixed connective tissue disease. Sometimes that is treated in place of a inherited connective tissue disorder, or a hypermobility spectrum disorder. And that usually leads to patients doing a trial of medications like Plaquenil or hydroxychloroquine. And sometimes there's improvement. We don't really know the whole mechanism of that. We don't really understand the whole process of seronegative arthritis. And when I say that, I mean the labs look normal, but otherwise they're treating rheumatoid arthritis. And so if there's improvement, great. But we certainly don't want to miss opportunity for improvement of other areas that may be related to a hypermobility spectrum disorder. And so, we can use that as an example for other areas too. So whether it's rheumatology, or, sometimes patients end up in the pain medicine clinic and they start
Mhm.
doing ablations and things like that, which I know you're familiar with. And so, uh, yeah, and again, those things may help, right,
Mhm.
temporarily, but you know, what will we see long term if you're just getting ablations and injections?
Yeah, and I'm so glad you brought up those are 2 great specific examples, because number 1, I hear from so many people that are so frustrated that their rheumatologist does not understand hereditary disorders of connective tissue, and they think that, these conditions, the triad, EDS, or HSD, POTS, and, MCAS, should fall under the umbrella of a rheumatologist. But rheumatologists, right, are trained in autoimmune conditions. And there is no one like perfect house for EDS and related conditions. So I think that's really challenging for a lot of people, because you're right. The rheumatologist is going to look for the things that they know how to treat, right? And they're going to treat them in the way that they know how to treat them. The pain clinician, whether they're trained in anesthesiology or physical medicine and rehabilitation. I feel like those are the two kind of primary specialists that will do interventional pain medicine. They also have their own treatments that they can offer, so they're not necessarily looking for these underlying problems. So I'm glad you brought that up, because the rheumatology, kind of mismatch of what patients perceive that but I'm having all these joint problems, so a rheumatologist should be able to help me. I think that's an important message for people to hear.
Yeah, and to add to that, I think that these conditions can almost present like a chameleon, in a sense that if you're looking as a rheumatologist at it, you're going to see it as a potentially rheumatologic condition. If you're going to look at it as a neurologist, you're going to maybe see it as a neurologic condition, and so on and so forth. So that the joke is that, if you have a hammer, everything looks like a nail. But
Right.
and I think that I'm hopeful that in the future that we have a better, faster way of making more precise diagnoses, quicker test results, lab results that are, high sensitivity, high specificity. And so we can, avoid the mismatch, even between specialties. And I think that would do service to lots of patients, because if we find some patients who are, again, getting, in a rheumatologic example, getting treatment for seronegative rheumatoid arthritis or mixed connective tissue disease, and there is some improvement, again, it may not be full improvement. So we don't want to miss an opportunity to have to have even more improvement, and really to complete the picture. And maybe, we'll find that there are some aspects of rheumatologic treatments that do have a place in hereditary connective tissue disorders yet, but we don't know. I mean, it kind of goes back to the question: is why do patients improve with Plaquenil if they're being treated for this condition, which otherwise we don't really know much about? So that's, something to be determined. But again, just like I've said, we've got to keep an open mind when we're seeing patients. We got to keep an open mind as far as the possibilities of where we can, move the needle forward.
And then I do think it's really helpful for patients to see a rheumatologist, especially if they do have joint swelling, erythema, or redness around the joints, to get those things evaluated for, right, and either ruled in or ruled out. Because as you mentioned last time with Hickdom's dictum too, that you can have more than one condition as well. So we want to make sure that we are, really assessing for things, properly. So yeah. So do you find that those labs are often helpful, or do you order like a rheumatologic panel, or when do you think that that's valuable?
That's a really good question, because, we can talk all day about how everyone is unique and there's so much differences between patients. But by and large, if we look at the most common conditions, again, being pain, muscle pain, joint pain, then it's not too surprising to see where there is a lot of overlap, and why, rheumatologists may get involved, because even though they're specializing in autoimmune disease where there's antibodies, or your immune system, your body is attacking itself, really, they see patients with joint pain, and that's kind of like their entrance, the entrance into the rheumatologist's door, as well as some signs of an autoimmune condition being present. And that's, where you're asking about labs, and imaging can certainly have a role there too, and X-rays and so forth. But for me, in my practice of when to decide to draw labs, and whether those are going to include autoimmune labs and that may be signal of a rheumatologic disease, I cast a pretty wide net at first, on the initial visit, because it's better to not miss something the first go around than it is to, have a have to draw it back and then and recycle or repeat steps. So casting that wide net usually does include some rheumatologic workup, and at the very least, an understanding of the presentation of symptoms too. So we can ask questions that give us clues about a rheumatologic or autoimmune disease being present. So we usually, we're taught these things in medical school, but for example, of like an autoimmune arthritis, it usually presents with swelling earlier in the day, and it improves with the day once we start moving joints around and kind of, releases those antibodies, it kind of dissipate and move out of the joint space. And it's swelling in certain joints. So we can get clues about which joints are affected that may be more likely autoimmune related, and hands and feet and ankles and the torso. So that would be the initial step, and that's even easier than ordering labs, of course. But the problem is it's hard to get a good understanding of those symptoms. And certainly someone can wake up with pain, no doubt about it. And does it get better through the day even without an autoimmune disease? That's also possible. So that's why I still do want to cast a wide net, as long as it's, again, not too much of a burden to the patient. It's not going to set them back financially if I draw some extra labs that would screen for autoimmune disease. And in doing so, there's, again, kind of a sequence, if we're talking about in that sense, of steps that I would take as far as labs go. So there would be initial labs that are better for screening. So we talked about having a high sensitivity. So they're good at capturing anything that's present and not missing something that's present, although they do also have a higher rate of being falsely positive, but it's better to catch it than not catch it. And so those things include things like, we had mentioned on previous episodes, so anti-nuclear antibodies, ANA, and maybe some of the rheumatoid arthritis labs that are pretty simple and easy to get, as rheumatoid factor. And then we can decide, are there other presentations of specific autoimmune diseases, whether we're looking at lupus or Sjogren's or mixed connective tissue disease and things like that. And then based on their presentation history, do we want to add those labs in as well?
Excellent. And yeah, I'm glad you brought up about the false positives with ANA, because that is so common. I have had positive ANA, intermittently, and I know so many of my patients have, and it can be confusing. So I'm glad you brought up about that. You're looking for high sensitivity, and you don't want to with those labs. You're looking to not miss something. You're casting the wider net. I think that's a great description.
Yeah, exactly. And when it comes positive, it's likely going to be positive again on future lab draws, just, so patients are aware. It wouldn't be too surprising to see that again. Why someone would repeat the test, that's a good question. I don't really know in every case why someone would repeat an ANA. I would say that sometimes we do repeat it because we add other labs with it, like other inflammatory markers and things like that, CRP, to get a better of assessment, even if it was positive but kind of ruled out in the past. Maybe we didn't get a full picture of what's going on, so we want to add some extra labs to it and be done with it. And usually this is not something that needs to be repeated every year. If we can rule it out, and then we can make a diagnosis of a hypermobility spectrum disorder or something akin to that, then we can get on with treatment. Of course, that's not to say that someone can't get rheumatoid arthritis, a decade later. So we do just kind of have to be mindful, again, of patterns and pattern recognitions of symptoms and presentations. So, but it's not likely that that would happen any more than what we would see at the frequency of the general population, just having an inherited connective tissue disorder.
Okay. That's all great information. We are going to take a quick break, and when we come back, we are going to talk about some of the pitfalls that we see and some key questions for clinicians. So we're going to take a quick break, and we will be right back with Dr. Knight. I'm so excited to tell you about my amazing Cozy Earth products. Every night when I'm watching TV, I love to snuggle up with my blanket, and I literally sit there and stroke my blanket as I'm watching TV. It is so comforting. And speaking of comforting, they have an amazing comforter that actually helps you regulate your temperature. They also have these socks that I've just recently been wearing, and they're so great. As you may know, I have a lot of problems with my feet, and so wearing these socks has really helped my feet so much. My feet feel so much better anytime I wear my Cozy Earth socks. And don't forget, they offer an incredible 100-night sleep trial and a 10-year warranty. So go to CozyEarth.com and use my code BENDY for up to 20% off. If you get a post-purchase survey, be sure to mention that you heard about Cozy Earth right here on the Bendy Bodies podcast. I hope you'll enjoy your Cozy Earth products as much as I do and make every day feel intentional. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. Okay, we are back with Dr. Knight, Medical Director of the UVA EDS Center, and we are talking about kind of the big picture when it comes to treatment and what are some of the things that we want clinicians to be thinking about, and what are some of the ways that we approach these conditions that might be helpful for other clinicians. So in terms of physical therapy, I think it's no secret that physical therapy can be super helpful for hypermobile patients, but it can also be harmful if it's not approached correctly, and if we have a therapist that's not, able to individualize their approach and things like that. So, do you approach physical therapy differently for hypermobile patients, or do you have recommendations that are different?
100%. And I can't tell you how many times I hear what someone say as soon as I say, well, physical therapy is usually recommended. Like, oh, I've tried physical therapy. It was terrible. And so we want to appreciate that, at least to start with, that like, okay, we recognize there are limitations. We probably tried to do too much too soon in the past, or just really not understanding that there was a diagnosis present then that could be related to a connective tissue disorder. So uh, when it comes to the next steps, yeah, it takes a certain amount of counseling and reassurance, but I have not yet had any patients who have seen one of the physical therapists that I work with that are very knowledgeable about EDS and HSD to have that same response that, it was terrible. It wiped me out. It was so painful afterwards because, and I've worked with these physical therapists. I know that they are very mindful of where to start and where to meet patients as far as what their abilities are. And it's definitely better to do too little at first than to do too much. I mean, it's part of the confidence and the trust of the patient at the very least, right? And because if what we have in mind is long-term improvement, it starts from the very beginning because we really want to gain that trust, and it's so critical.
Yeah, I think that trust is a really, really crucial piece. And sometimes, we have these patients, they look quite healthy. So they will go in for an appointment and the therapist thinks, oh, well, they certainly will be able to handle this load. And so, yeah, absolutely. Starting low, going slow, and really, listening to the patient. And I think another important part of that is for the patient to give that feedback back to the physical therapist. Because a lot of times because I've had a lot of patients tell me physical therapy doesn't work for me. And I said, well, did you go back and did you talk to the therapist about what happened? That was way too much. I ended up injuring myself or whatever it was. And understandably, a lot of the times they didn't go back. So that therapist, number one, doesn't learn for their own, career. Like they don't learn about, oh, well, I did too much with this one particular person. So maybe in the future I should be more cautious. And two, they don't have the opportunity to improve the plan for that specific patient. So I do think that when people are able to do that, it's very important that they do that. But like you said, the trust piece is so important. So you also have to kind of trust your gut in terms of, is this somebody that they just prescribed a little bit too much, but they're going to modify their plans, or are they too rigid in their thinking and they're not going to be a physical therapist that really is going to be somebody that I can work with long term. Finding that fit, I think, can be hard.
No, well, that's exactly right. It's got to mesh well, and it's the therapist and the patient have to certainly be in sync, and it's part of the whole treatment process. Because I'd say the best scenario is a case where, yeah, you pointed out 100% that the physical therapist will be open to receiving feedback, and the patient will give feedback, and then with time that's tailored to that individual patient. And then the physical therapist is aware to look for improvements or lack of improvement and where to kind of shift the direction of the therapy. So that's really the most ideal course of physical therapy where it is engaged in both directions and also maintain to a point that the physical therapist can use their experience and their skills to change treatment or shift it if they need to, just based on how the progress is going.
I'm curious to get your thoughts on this too. So I think for in my experience, one of the most frustrating things about physical therapy in patients with EDS and HSD is the insurance model of, you have a problem with your ankle, and so we're allowed to treat your ankle. We're going to do scoring of, how functional or dysfunctional this particular body part is, and then we're going to assess that over time because we want, the insurance company wants to have these metrics, right? And you need to be improving enough, but not too much in order to get more sessions approved, right? So, and then people with EDS and HSD are going to have something different. Maybe their ankle is doing better, but now that threw off their shoulder or their hip, or so to me that is a big part of the problem is the way insurance covers physical therapy.
That's an excellent observation, and it couldn't be more true. I mean, it's just such wacky world that we live in the medical health insurance world, and what we have to do to work around it or adapt to it. But yeah, you're 100%. I see these cases all the time as patients say, well, you know, physical therapist told me we're only working on the ankle today. Don't even try to mention your shoulder or your kneecap or something. But yeah, you're absolutely right that part of the therapy may will certainly involve other joints and muscle groups, and there may be, favoring one group or the other that leads to different effects. And so it's 100% accurate. You've got to keep all of those regions involved and in mind, and to treat and how we kind of sneak around the insurance barriers that comes with time and experience, and every insurance provider is different, of course. So where their limitations lie may change, but usually a good physical therapist is aware enough to at least, say, okay, well, you know, we're working on the ankle, but we know that this muscle group could potentially be involved. So here's some things that you can take with you to kind of work on. And that's what we would like to see a physical therapist to be able to deliver those resources that are ultimately just going to improve them overall.
And your point about change over time is also super important. I was in physical therapy for my shoulder, and then I injured my foot. So they opened a second case. So I would go in one day to have my shoulder treated. I would go in another day to have my foot treated. So talk about, I'd have to take extra transportation time, of course. But at that point, this clinic still covered, still accepted, my insurance payment. And then they dropped my insurance as one of their, insurances that they would cover, because the insurance company dramatically dropped what they would reimburse the physical therapist for. And I know the owner of the entire chain of clinics, and he's like, I could not keep my doors open if I would accept insurance payment from this particular person. So it can be really challenging from the standpoint of trying to run a physical therapy practice as well, because of the way things change over time. And so I've ended up going outside of my insurance, and that way I can have somebody address whatever it is that's bothering me. But I recognize that I'm extremely fortunate in order to be able to do that. And most people do not have that ability. But that also sometimes leads them to other options, which I think could be super beneficial, like Pilates, gyrotonics, gyrokinesis, working with movement specialists that are, maybe not physical therapists, but that maybe it's more affordable if your insurance doesn't cover a lot of physical therapy anyway, if you find someone with the right expertise. Do you have certain other movement therapies that you find to be particularly helpful?
Yeah, I think you hit them, and I love it when I hear patients may already be engaged in them, and sometimes they are just by chance. And there is actually a physical therapist I work with who was I don't know what the levels of training are, but Pilates was her kind of method of delivering therapy. And that's great. Pilates is fantastic. I know a lot of former dancers, like yourself, may be into Pilates, and
Yep.
I, I never really learned what's the matchup there. Is it just because it's similar type of movements?
So Joseph Pilates originally was a dancer, and he originally developed Pilates for hospitalized patients using like the hospital bed, and yeah. But there's a huge connection there. I think a lot of dancers get introduced to Pilates, and it appeals to them for a variety of reasons. And yes, I know a ton of dancers who then later become Pilates instructors. It's a very that's a very
Yeah.
common, yeah.
I knew that. That's right. I didn't know that exact history, but I knew there was some connection there. So, yeah, and this can certainly be a resource among other types of movement therapies that we have patients sometimes who'd say, I like you gave the example, the insurance runs out or won't cover it, and then they kind of reach this fright that I'm not going to be able to receive any more treatment, and I'm kind of at the end of the road. But if we can at least engage in some of these other movement therapies, with or without someone guiding them, obviously it's much better if there is someone as a trainer to help guide and learn the specific movements of direction. But it's also not to say that patients can't learn those themselves once they've worked with someone, or get some other ways to be educated on those. I know there's a lot of great movement therapists out there that are connected to the world of EDS and the EDS Society, and so they've written books, they've got webinars and things like that. So any number of ways to be engaged, and really when it comes down to it, something is better than nothing. So that's again getting the confidence of the patient that they can do these things. It usually starts with that consultant or physical therapist, at least to get them into place where they feel comfortable and they feel confident to engage in some of those movement therapies. But it's really important for them to be engaged, and because we definitely do want to get them in a place where they're comfortable doing it and confident that they can do it correctly.
Yeah, kinesiophobia, fear of movement, is such a real thing. And I remember when I was writing my first article about hypermobility, joint hypermobility, connective tissue disorders, and pain management, and I hadn't really come across the word before, and I saw the word kinesiophobia, and I thought, "Oh my gosh, that's exactly what has happened to me, and I'm trying to get over." Because it can be so challenging if you hurt yourself doing, small things, then and so many movements feel uncomfortable to you. It can be very frightening. So I think that, like you said, working with a movement therapist of, whatever type, if you have a good rapport and if they are a good listener and they really recognize the person in front of them and customize their treatment plan for this person. Is this somebody who, needs to be encouraged to do a little bit more, or is this somebody who really needs to be kind of held back and kind of given permission because they tend to push themselves too hard? I think is key.
That's it, and because you do want to start somewhere, and so knowing where that patient is starting, as it is kinesiophobia, the fear of movement, it may be tied to one specific movement, but then that means that the downstream effect is that you kind of stop global movement and movement in other areas for fear of triggering the same thing. Whereas you can actually potentially move other areas, and that may even improve the area that is deconditioned or more painful as a response. So we're building muscle and all the whole biological process of building muscle or breaking down muscle and rebuilding it. There is a healing effect from that.
Definitely. And what do you think about, you already mentioned like there's, webinars and there's all kinds of like virtual options or remote options, video options and things like that. What do you think about the balance of that versus doing things in person? When do you think that it's really essential for someone to be working with someone one-on-one in person? Do you think there's times where that really is a necessity?
There certainly are, and again, it's meeting the patients where they are, and I have patients who are eh, really debilitated, they're wheelchair bound, bed bound, and things like that. And I've actually come upon this service recently I wasn't aware of it, and I really didn't know that that was even in practice of it. But there are some physical therapy groups, at least I've been knowledgeable about in our region, that go to patients' homes and will provide. And I know they do it, from geriatric care and patients who have had major surgeries and things like that. But for the EDS and hypermobility community, that's can be a huge lifesaver because if they're in such a condition that it really can't even get out to see someone coming to them, it could be a really great option. Now, I understand that is limited to only certain geographical areas. So back to your question is when they want to meet in person with someone, when they want to come in, and that's usually always the best place to start, one-on-one. That's why a lot of our visits, almost all of our visits, are in person initially, and we want to see how the patient looks and how their body moves and how we can get a close exam on it. So that's usually the ideal situation. But seeing that there are other limitations, and whether it's insurance or whatever, if it's something that can be done by video or something that they can do themselves online or through online programs and webinars, then again, something is better than nothing. So, by all means, go for it.
Yeah, some of the things for us, I feel like, looking for pyogenic papules or atrophic scarring or, soft velvety skin, like you have to touch their skin obviously in order to see if you think it's soft and it helps to have touched a lot of people's skin in order to, because that's obviously a very yeah. So when it comes to seeing a physician or somebody who might be making a diagnosis, that is, I think, an essential thing to do whenever possible. So, okay. When it comes to hypermobile EDS in particular, because we know that the majority of people that have EDS, that's the much more common subtype, of course, and HSD, POTS, mast cell activation disorders, etc. What does getting better actually mean?
That's great. And I really like that because this just is a running theme that this may be different for everyone, right? And the presentations and symptoms may be different. So what are our goals? And those may be different. And that's why we bring in what I had mentioned another occasion is what we call now shared decision making, where we have a goal that applies to the patient and is also the patient's goal rather than us just saying, oh, we're going to hit this metric and do whatever it takes to get there. That amounts to then is uh, seeing really if our mission is to deliver function and get the patient going and active and really ultimately just having a higher quality of life, then we need to understand what brings them quality of life. What do they enjoy doing? Do they like working? Do they like ice skating? Do they like, painting? And so how do we target that? I mean, love if everyone could go out and climb a mountain, but there's lots of people that are very good health that won't go out mountain climbing. So why would we even bother shooting for that, right? Let's just go for something that fits them, that fits their wishes and their desires and what's achievable.
No, I think those are really, really great points. And I was told when I was in my worst situation and feeling just really, really terrible, I had a colleague who had a pain management practice. I was working as an anesthesiologist in the operating room. And this colleague of mine said to me, a lot of patients make the mistake of thinking that they need to get the pain to go away and then start doing what they love again. But really, if you can, you want to start doing what you love and reincorporating that, even if it looks different for a while. And starting to try to get more of a quote unquote normal life back so that the pain doesn't take over your whole life. I mean, it was for me, it had taken over my whole life. And I'm sure you've seen that a lot.
I see it a lot and I hear about it a lot. And I'm just going to have to go way off on a tangent here and give a plug for Oprah's book club because I'm listening to an audiobook right now. It's fantastic. It's called The New Earth. And it's exactly to that point you just made, which is, what are we expecting to find joy from? Are we expecting to find joy from the things that we do from them, or are we going to find joy from doing them? And the idea is that we focus on finding joy or improvement in doing the things rather than having completed the things. Then I think we're going to be much better off, because we're not going to have mismet expectations. Well, I've done this now and I should feel better, and I don't feel better. Why not? It's not giving to me what I want it to give to me. Again, I think that can go with treatment. It can go with physical therapy and go to exercise, uh, to the point that doing those things at a level that is comfortable. And I don't know that physical therapy should really bring anyone joy, but at least doing it in a way that you're comfortable doing it and you're satisfied with the process of it all. I think that will meet a higher or better response than, just like grinding through it and be like, I did it. Now what? What else is there to do? So, and it doesn't have to just be physical therapy. It can be other methods of treatment. It can be mind body therapy. It can be, just anything else that you find comfort doing, that is, meant to improve your condition.
Yeah, I love that. And how do you set expectations with patients that are honest without taking away hope?
I think that ties in exactly what we're just talking about, because the expectation that we want to bring is that, and what we want to achieve is ultimately improving quality of life, and so there's so many different ways to approach that, and to see what that is exactly, and so I would like to say that, as I get to know patients, and understanding what they enjoy doing, what are their hobbies. It's usually one of the first things I ask patients, and they usually kind of give me a funny look. Why you even bother asking me that? Or maybe I did have hobbies one day, but they're far gone, from where I am now. But not only hobbies, but what is it that you like to do, and what do you enjoy doing, and what is it that's causing you to be obstructed from doing that? And so, the expectation then accordingly is that we want to get to a point where we can do those things that you enjoy doing. If there is still some subluxations that happen from time to time, that's okay. And if we're able to get to the place where we are making improvement, then that generally what we see cycles upon itself. More improvement begets more improvement. So just the act of doing it can help over the long run period. And that's the starting point, is at least just let's take small steps. We talked at the beginning of this episode about magic treatments, and we don't have those magic treatments. We don't want to promise a magic treatment right from the beginning, because that's definitely going to be a sorely missed expectation. But maybe the patients will see some magic in the process as they're going about it if we set those expectations accordingly. And if we start low, we go slow, and even with those goals of treatment, if we have a small goal that we can work towards in the short term period, we can usually achieve bigger goals over the long term period.
Yeah, I think those are all very consistent with what I've experienced both personally and professionally as well. You want to just start things going in the right direction, and that can, just like pain can beget pain, right? So once you start having something in pain, everything else starts to hurt. Um, okay, so for clinicians, how can they avoid overtreating symptoms while still providing adequate support?
I think this is a common problem, and I would venture to say it's more common in the practices where they have less time and less attention to what may be underlying issues. And we see it, far and wide in so many areas. So, can use an example of someone coming into. I used to work as a primary care provider straight out of residency, and we talk about you know appropriate treatment, guideline based treatments, and someone's got a cold in a short amount of time, and in a lazy response, you maybe just be thrown antibiotics. You just take your antibiotics, go away, move on to the next patient. And there's so many things that go wrong with that. not to mention big societal problems where we end up with antibiotic resistance and things like that. But it's the same thing. I would posit that there is with a patient with hypermobility spectrum disorder that comes in with, back pain, and we just, give them some medication that's going to wipe away the pain there and now, but ultimately, back pain comes back 2 weeks later, and then now it's associated with knee pain. And then we're going to do stronger medication and keep running through that cycle. So we really have to do our due diligence that first visit, and it may take more time, but it's a better investment for ourselves as providers over the long run, and for the patients themselves, of course, too. So I think that's where we have to kind of draw the line between just treating symptoms and understanding what may be the underlying causes and mechanisms involved. And even if we don't understand every single exact mechanism of hypermobility disorders or mast cell activation or POTS, because we don't, there's still a lot of mystery to it. If we can at least recognize that those may be present, and then if we can tailor the treatment to target an underlying root cause rather than putting on the so-called Band-Aid, I think we'll find better overall outcomes.
And how can patients tell the difference between a thoughtful treatment plan and a reactionary one?
I would like to think that in most cases, a provider would be describing the treatment process and the process that they go through to arrive at that treatment. And in terms that patients can understand too, of course. So just throwing out a bunch of medical jargon and say, here's your treatment, I wouldn't say that's acceptable. I think we usually, in the course of a good clinical visit, invite feedback from the patient and understanding from the patient that that we as providers tell them that they grasp, and they can kind of summarize it for us so we understand that they grasp it. And so I think that's what patients would want to look for a provider at giving them the opportunity to summarize their treatment plan and why it's there and what it's intending to target, and to make sure that the patient's target, their goal, is in line with what we would call this shared decision-making process, that the provider has kept their goals in mind as well.
That makes sense. And yeah, it just can be so challenging, and so it's so great for people to have this information for both patients and clinicians to be able to, hopefully get improved care in the primary care setting, because these patients are in a lot of specialist offices, but the primary care really should be the person who is able to, recognize, like you said, recognize and at least provide some introductory tools and things so that patients can get care, locally when possible, and then if they need to for some of the more, complex things. But it's a shame that most people need to go someplace else, even for some of the basic things, I guess is what I'm saying. Yeah.
Yeah, and I would like to think that in due time, primary care doctors are going to become more knowledgeable about these conditions. And we're not there quite yet, but awareness is growing, the science is growing, the educational resources are growing. And so I would like to think with time, primary care doctors will be more knowledgeable. And I think what we would see then at that point is that they are more open to considering some of the treatments themselves. I mean, it's not so far out of reach of a primary care doctor, really. And it's just a matter of having some basic knowledge behind it. And you know, uh, I can't say it's so easy because I've been doing this for years and I haven't really figured out everything. But I could say, as my background in a primary care doctor, this wouldn't be so far-fetched to think that some of the at least common initial starting points of treatment could be available in a primary care setting.
Yeah, that really helps to have your perspective, because I kind of function as a, quarterback or primary care now for my patients, that, I might be treating more so their pain, but then they'll be asking me about other things, not treating their, UTIs and stuff like that. But I think that having your perspective on the realisticness of, if that's even a word, of, having primary care doctors starting to really, recognize these conditions and be able to offer some type of treatment, I think is really, helpful.
Yeah, it's interesting to think about what is medicine going to look like in the future, and certainly, obviously, we're here today talking about EDS and HSD. How is that going to be involved between specialists and primary care if we do get to a point, like I mentioned, where primary care doctors are more knowledgeable? There's also primary care models out there, and maybe this is a really good thing for a future episode too. But primary care models that are so overburdened, where they have incorporated AI into their practice as much as possible to kind of help facilitate patient access, where otherwise there's limitation of providers and primary care doctors. But there are some AI tools that can be used to garner information from patients and their medical history and kind of synthesize that for primary care doctors so they can run through some of those things more efficiently. And so what does that look like in EDS and HSD? I don't know. It's a good question because these are very complex conditions too. Is it too complex for AI? I don't know because we haven't tried yet. I mean, there are some things and tools that we are looking at to use, at least in the research space first. But does that mean that we are able to open those doors up to the clinical space too? So time will tell. And these technologies are evolving so rapidly. So it's really time will tell, but it may not be much time. It just may be a matter of months or years that we see things change quite rapidly.
And I feel your hack coming on here. This is, I always end with a hypermobility hack. And are any of these tools that you're mentioning things that patients could access now themselves, or are they things that the clinic has employed and then they have to share it with the patient and then the patient fills it out?
Yeah, so this could be a great hypermobility hack. So thank you, because I had not thought about this ahead of time. Yeah. So the short answer is yes. I think that these are tools that can be available to patients here and now, and I think they are adequate because, going back to some of our previous conversations when we talk about what a patient would want to do to prepare for a visit, and I mentioned taking notes or jotting down things on your phone. Totally open to that. I love it when patients do that because I know that I'm going to meet all of their marks that they had anticipated, and we'll have a chance to go through those. And it's not something that comes up after the visit. But taking that a step further, and I've had patients do this already. If you want to, you don't have to, but you can take some of those notes. You can add a little bit of your history, and you can put those into one of these, whether it's ChatGPT or Gemini, or pick your favorite large language model or chatbot, and run it through there and get a summary and see if that fits your description of your condition. And sometimes it puts things in easy to read format and bulleting and bold lettering and things like that may be useful to the provider. So no harm in doing that. And certainly in the case where you're going to see a provider, because the downfall we see with AI tools and really just anything you read about online is that patients take that upon themselves to just kind of jump to treatment that may be unsafe or may be incorrect. So as long as you're going into the provider, I think it's totally safe and kosher to do that.
Yeah, I love that. And I've had a lot of patients who did exactly what you said. And then the AI tool helps them organize the information so that they have, bullet point, concerns and symptoms by different system. And of course, that helps us to be able to see that. So actually, I'm seeing somebody later today that did that exact you can just tell, right, that it's AI generated, that they have this. It's like, that's great. That's going to help me. It helps you. So yeah, I love that hack.
And it's funny, the patients are kind of sheepish when they do it. Like, I apologize. I'm sorry. I'm like, oh, it's great. It's actually a very easy to read summary, and I appreciate you taking the time. So yeah, it's just fine.
Yeah, that's a great hack. Okay, well, thank you so much. This has been a great conversation, as always. Can you share with people just a little bit more about what you're doing at UVA and where they can learn more about you and about the clinic?
Well, what we're doing is what we're hoping to do is get all of these things right that we just spent the time talking about today. So shared decision making, targets of treatment, and all those things. There's a lot going on. But at least for the time being now, we're building the team of providers and staff that are all on the same page with with this message too. So we meet regularly and we discuss patient cases. And I think that's really what is ultimately in best service to patients, because we know that the best outcomes are delivered through multidisciplinary care. So we obviously need to build those bridges. So that's what we're doing at the University of Virginia EDS Center. Having said that, we want to not only deliver on patient care, but we want to advance the science and make groundbreaking discoveries as we can. So that's all to the importance of delivering better treatments. And maybe we will get back to from what we discussed at the beginning of this episode, a magic treatment one day. So that's all to the purpose of working in that magic to find patients in a good place that they can all live high quality of life.
I love that you have those multidisciplinary meetings because, we all know, like cancer conference, they'll have the radiologists and the general surgeon and, all the different people that are oncology, et cetera, all there to discuss one particular case or a few cases that week. So I love that you're doing a similar thing for EDS. That's fantastic.
It really works, and we find joy in it because otherwise we'd be scratching ourselves, scratching our heads alone, and you kind of feel lost in it. And so having that kind of team model it's so supportive.
Mm-hmm, mm-hmm. Okay, all right. And so, in terms of where people can find you, where do you see? Because I know you're not super active on social media, but you are on X, right? Are you on any other platforms?
Yeah, that's the main one. I'd say, I get so busy checking my emails day in and day out. I just really have a hard time keeping up with it. But I'm glad that you've got this platform out there. So that takes away some of my efforts to have to try to get the message out there to others, which I think is so critical. So yeah, I'm on X and LinkedIn, although I haven't been looking for a job, and I won't be looking for a job anytime soon.
Yeah.
We are hiring, but I think we've got a pretty good place that we've found all the individuals at this point that we want to hire, maybe some more down the road. So maybe keep an eye out on LinkedIn if we've got other job opportunities coming up, because that can certainly be the case because we are growing very quickly.
Amazing. That's great news that you have people in the pipeline that you think are going to fill some of those positions that you were looking to fill. So that's fantastic. That's
It's very
exciting to hear.
exciting. We've got a lot of work to do, so we need them here yesterday.
Yeah, exactly. That's wonderful. All right. Well, thank you so much again for taking the time out of your busy schedule to chat with me. And I really enjoyed our conversation.
Yeah, it was great, Linda. I enjoyed it as well.
Well, I really enjoyed having another conversation with Dr. Dacre Knight, who is Medical Director of the EDS Center at UVA. And I want to thank you so much for listening to this week's episode of the Bendy Bodies podcast. If you'd like to go deeper, I share additional education, clinical insights, and resources in my newsletter, The Bendy Bulletin, which you can find on Substack at hypermobilitymd.substack.com. You can also help us spread the word about connective tissue disorders by leaving a review, sharing this episode, or sending it to someone who needs it. These small actions truly make a difference in raising awareness about conditions that are still widely misunderstood. And don't forget, full video episodes are available every week on YouTube at Bendy Bodies Podcast. As many of you know, I offer one-on-one coaching and mentorship for both individuals living with connective tissue disorders and people caring for them. You can learn more about these options on the services page at hypermobilitymd.com. You can find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, X, and LinkedIn, all at HypermobilityMD. As part of our collaboration with the UVA Ehlers-Danlos Syndrome Center, we also want to share some of their helpful resources. For questions or appointment inquiries, you can contact the UVA EDS Center at ruvaedscenter@uvahealth.org. Again, that's the letter R as in Robert, UVA EDS Center at uvahealth.org. You can find answers to common questions at uvahealth.com/support/EDS/FAQ. Our incredible production team is Human Content. You can find them on TikTok and Instagram at Human Content Pods. As you know, we love bringing on guests with unique perspectives to share. However, these unscripted discussions do not reflect the views or opinions held by me or the Bendy Bodies team. Although we may share healthcare perspectives on the podcast, no statements made on Bendy Bodies should be considered medical advice. Please always consult a qualified healthcare provider regarding your own care. For more information about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, HIPAA release terms, or to get in touch with us, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.